Hello. Hello. One, two, three. Hello. One, two, three. అసలే మంచిగానే వస్తుంది.
Good evening to everyone and welcome to today's session. Yesterday we had a little technical stumble, but today we are not like that. Minal, Srishti, Prajakta, Commandant, Rekha, Sahitya and everybody. Aapka Farmaish, the NEETPG review with Dr. Murali Bharadwaj every day across 365 days. The live broadcast with all the students across. Rocket says, sound is very good. Thank you. Yeah. Continuing our discussion on November 2017 AIMS question paper. Right? Now, a patient with HIV with diarrhea treated with trimethoprim sulfamethoxazole. The diarrhea subsided but the fever persisted and there is an intracellular fungi which has been shown to you. So, what is the organism? It is Isospora bellii, which is the most common organism responsible for the development of the diarrhea in a HIV positive immunocompromised individual. Spores are the infective form. It's an intracellular budding yeast. It can lead to systemic disease and it can be grown on the Severod's agar is what need to be basically remember. Shika Munka is asking subject wise, let us discuss. We will do that. But my preference is 2 years, 4 question papers, 97, 98 and 96. AIMS, NEETPG, JIPMA and DNB. Let us quickly review paper wise. So some 2000 questions, most recent ones, you are all well equipped. And from there, we will continue with our subject wise reviews every day. Yeah, so please bear with me. Now, what is this organism which is a fungus with a narrow angulation is what you are able to see. It is the acute angle branching aspergillus is what I want to underscore to all of you. Now, yesterday we were discussing this question. From Himachal Pradesh, the history of a thorn prick, verrucous lesions, and you find granulation. So what is this organism? Chroma Blastomycosis. But you all asked, why can't it be sporotrichosis? The reason being that granulomatous inflammation with the giant cell containing large pigmented muriform cells is the classical feature of the chromoblastomycosis is what you have to basically remember. 1,3-beta D-glucan is very important for identification of which organism. Even if you don't read also you can answer. Why? If candidiasis is there in the options, candidiasis is the answer. That is what you have to basically remember. So, for the detection of invasive candidiasis, we use latest agglutination, sandwich ELISA, then inulase, beta 1,3-D-glucan. These are all the ones which are used to detect the fungal antigens in invasive candidiasis. Clostridium difficile. What is the best method if you are suspecting, let us say, somebody with the history of antibiotic usage in the background, in hospital patient with dysentery, you want to prove that possibly Clostridium difficile pseudomembranous colitis, what is the way? Toxin detection by ELISA is considered to be the investigation of choice. We can do stool culture, latex agglutination, tissue culture assay, and ELISA for toxin A and toxin B is what need to be remembered. But out of all, it is the toxin detection by ELISA is a very handy way by which you can be able to make a diagnosis of the pseudomembranous colitis. Viral hemorrhagic fever, which belongs to Africa, reported even in Gujarat, leading to a lot of mortality. Which one it is? It's more a IAS exam general knowledge question. Crimean-Congo hemorrhagic fever. It is a tick-borne viral disease of the Bunya viridae family, and first case in Gujarat, and 4 reported deaths, and unfortunately the doctor and the nurse who were treating, they also died among the 4. So it is an arbovirus belonging to Bunya viridae, and under that it is a norovirus. Under the norovirus family, Crimean-Congo fever is what you have to basically remember. Because a doctor and nurse died, that became an MCQ in the AIMS exam. The blood spills that happen in the OT or in the wards, how are you going to clean them? It is the chloride compounds, 0.5% chlorine solution, which is used to treat the blood spills in the client care areas, is what you need to remember. Now, this is an organism which has an endoflagella, outer membrane, periplasm, DNA in the nucleoid. Considering all this structure, most likely what is this organism is a examiner's question. It is Leptospira. It is also closest to differential diagnosis for leprosy is what? Leptospira is what? Malaria. मलेरिया में जॉन्डिस होता, सेरिब्रल मलेरिया में कोमेटो स्टेट में रहता, मलेरिया में रीनल फेल्यूर होता फाल्सिपारम में, जॉन्डिस, एनकेफेलोपैथी, renal failure, these are also the features of leptospirosis. So closest differential diagnosis whenever a villager comes with all that. Biofilm forming bacteria, they cause antimicrobial resistance. So what is the mechanism of that? They create a mechanical barrier, they increase the excretion of the antibiotics out of the organism, and they alter the metabolism, and they make antibiotic to penetrate slowly, and some of the bacteria will differentiate into a protected phenotypic state. So a resistant phenotype को बनाने के लिए that biofilm is a very conducive factor, and they alter the microenvironment that will favor the bacterial growth. That's how the biofilms basically function. Since morning I had been talking, my voice is overused, so just apologize my laryngeal edema. Now doc, what is this organism that is being shown in the image? Once more, I like to tell you, हम इस देश के वासी हैं जिस देश में टीबी बहती है. If mycobacterium is in the options, don't even look at the question. Answer mycobacterium, that becomes the correct answer. So Mycobacterium tuberculosis on the Gilles Nielsen stain, examiner, very innocent guy. He thinks that you all guys have done that heating, Gilles Nielsen and all that sincerely in the microbiology days. Oh, microbiology are the days. That is the time we are at the heat of romance, first romance. So 1.5 year कुछ भी नहीं पढ़ते anatomy physiology pass होने के बाद. So who has seen? Only few guys with big spectacles. They are very sincere academicians in the class. Otherwise, hum sab anguta chap in the class never cared about academics. Identify the virus based on the given cycle. Virus is entering, incorporating into the DNA, etc., etc. So this is the classical feature of hepatitis. So without a question on HBV, there is no NEETPG, no AIMS, no JIPMA. So there are at least 100 topics out of the 650. Invariably, question paper will have those 100 questions. Paper out. So you should be super smart in those must read 100. Remaining 550 may, another 200 are great to read. That makes you stronger. At least some 200 out of the 650. Please read if you can, kind of thing. Beyond that, there will be 2,000-3,000 topics. You don't read also, kuch bhi nahi hota. All winning, losing is to know whether you are good with that 100 or not. That is the purpose of UMedico's quizzes. Play quizzes on the high yield topics. At least 8 by 10 score ana har ek quiz mein. That day you are good in that topic, you can move ahead. Fecal smear shows this organism. So what is this organism? Belantidium coli. How do you know that? Typically, it will have a trophozoite and a cyst. Trophozoite will have two visible nuclei. That is how you will find and identify the presence of this fecal smear may. Belantidium coli is what you have to basically remember. And a sausage-shaped macronucleus is another very important clue. Deepayan Banerjee is asking, sir, what are those 100 topics out of that? Jaldi batao na. ये सब शाम बर्बाद क्यों करना है हमारा जिंदगी? Yes, you are right. So we have given 650 topics in 19 subjects. Subjects like medicine, 80-90. Around 90 topics are there. Surgery में about some 60 topics are there. अगर आप क्विज को गए तो यूमेडिको ऐप में एक सब्जेक्ट के ऊपर गए तो you have the list of the topics in the descending order of high priority made available. The 650 are being distributed. Top 10 topics in each subject. ले लो. Major subjects. First, get good with them. For example, you take pathology. Glomerulonephritis के बिना क्वेश्चन पेपर अगर है तो मुझे दिखाओ यार, मैं अभी त्याग पत्र देता हूं. ठीक है? Without a question on diuretics in pharmacology, anti-epileptics in pharmacology, pharmacokinetics में volume of distribution, bioavailability, blah 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 वो सब रहता ना, उसके बिना अगर क्वेश्चन पेपर है तो मुझे दिखाओ. नहीं होता वैसा. Top 10 topics in that list also. First to finish them. In the every UMedico quiz, 8 out of 10 score at least achieve करो. Then अगर सीट नहीं मिले तो मुझे मेरा जिम्मेदारी. That's what I can assure you. Chirag Goyal is saying, sir, give me a sample paper before NEET. At least you should also become controversial. Na? Yeah. Every day, come evening, spend time with me. Right? That is enough. You will get the seat, I am telling you. Next 65 days, 65 into 2 hours, 130 hours मेरे साथ spend करो. Seat नहीं आए तो मुझे पूछो. Perseverance is all the difference between winner and loser, doctor. Let me tell you. इस game में क्या चाहिए? Tomorrow, even in hospital practice, when will you become successful? जो branch आप कर रहे हैं, that particular subspecialty where your expertise, consistently, if you are practicing within 2 to 3 years, without knowing also, you will have a lot of patients, relatives, relatives. You don't need to do any marketing also. Perseverance is all, doctor. Unfortunately, we should have patience for that. We lose the patience. We get disheartened. We go by comparisons with somebody else. And we bring discontinuity into the story. No, you're all brilliant guys. Just continue fighting every day. That's how last 60 days bring all difference. Now, what is this organism on the stool sample? Classical question of AIMS. AIMS does a wonderful homework. They have got a special group of people who will create image-based original questions. Very nicely set paper. Their question bank, everything. There's the only institute that does academic exercise in assessment, evaluation, and everything. Right? Like a USMLE Board of America. So it is Giardia lamblia. Classical question. So it is tetranucleate with a cyst wall, with a median parabasal bodies. This is how you recognize Giardia lamblia is what you have to basically remember. Urine lamb, LAM lamb, is used for the diagnosis of, was the AIMS November 2017. What is the Murphy law I told you? अगर टीबी है तो आंसर क्या होगा? हम इस देश के वासी हैं, जिस देश में टीबी बहती है. You don't know what is lamb, what is wolf. Still answer will be tuberculosis. Anuj Nigam perfectly said BBBB. B में क्या है? B के पीछे क्या है? माइकोबैक्टीरियम है. Mycobacterial lipoarabinomenon antigen is used in the urine, and it is the way by which a dipstick can be able to detect the tuberculosis is what need to be remembered. Ravi, don't tell anybody that Murali Bharadwaj teaches like this, that agar TB hai to TB hi answer hai, rakho bol ke. Huh? So, yeah. If you are too sincere student, doctor, seat नहीं मिलता. जरा ये छोटे मोटे नखरे आना है, right? अगर आए तो, if you are a lazy guy, the chances of becoming a great man are higher. Let me tell you, right? Because lazy guys discover shortest solutions, fastest solutions, right? So don't be too hardworking. Peptidoglycan, arabinogalactan, mycolic acid, lipoarabinomenon. These are all the ones which are the part of the mycobacterial cellular envelope is what you have to basically remember. Now, in which malarial parasite you see relapses? Plasmodium vivax and Plasmodium ovale, the classical malarial parasites where relapses are seen. Nothing is an offense which is done by a person who at the time of doing it by reason of unsoundness of mind is incapable of knowing the nature. That is the McNaughton's rule of criminal responsibility is what you have to basically remember. According to the Niston's rule, what is the order of development of the rigor mortis is a very, very important question. Good. Parallelly keep answering the questions so that you are actively engaged in the discussion. I am very happy to see 225 online students across the country. Please bring at least 5 to 6 new friends of you to our religious conglomeration so that we become a bigger religion of, in IIT coaching, there is one teacher, he doesn't charge anything. Super 35 it is called. He will just pick up 35 students and see that they get into the IIT. You are all what? Super 1000 of NEETPG as the students of Dr. Murali Bharadwaj. top 1000 ranks in NEETPG should be all our evening friends who meet every day to discuss together, right? So please bring more and more, put the link in the Facebook here and there, social media, wherever you are there, so that you get a chance for more and more to join. Orbicularis oculi, facial muscles, thorax and upper limb. That's how it spreads. Niston's rule is rigor mortis does not start in all muscles simultaneously. It starts in the involuntary muscle, myocardium, then in voluntary muscles. In the voluntary, eyelid ke baad neck, neck ke baad lower jaw, then face, then chest, then the upper limb, then the abdomen, then the lower limb, then finally goes to the fingers and toes is what you have to basically remember. A 14-year-old rape victim with 22 weeks of gestation comes to the hospital. You want to do all except what? So, whether it is rape or not rape, beyond 20 weeks, abortion, even on patient request, is not considered to be legal. That's what you have to basically remember. She is a rape victim 22 weeks back. So, no point in taking vaginal swab now. Urine pregnancy 22 weeks mein you have got sufficient diagnosis. You don't need a pregnancy test to prove that. And a male doctor can examine with a female attendant. Very important, doctor. Tomorrow in your clinical practice, these are the few ethics that very few people teach. But if you miss those points, however good you are, you may end up in a wrong note of the law, wrong side of the law. Always with a female patient, as a male you are examining, you need to have on the side of you a female attendant or a female nurse on the side of you while you examine. Most important rule of your life. Then another thing, while you touch the patient also abdomen, you need to warm your hand and then touch. And while touching, you should tell the patient that you are touching her, you are going to examine her. Generally, हम government hospital में क्या करते? आते फट liver, spleen, ashes, they are our property, we will examine. No. So that is most important thing. Patient also feels very happy. Even if you are giving IM injection, you must tell, I'm giving a small injection, it will be less than an ant bite, don't worry, and then you should give. You are the best doctor. If you just do that simple way of your disclosure to the patient, he will love. Similarly, when a patient walks into the OPD, call with the name. Hey, Shailija, how are you? Please come. How is? Don't start immediately. What is your complaint? Fatafat bolo. How is your husband? How is your children? How are they? Very good. Very good. Ah, bolo beta. Abhi kya hai? Then the patient will be very happy that you remember the name and you are addressing just not like a routine doctor and patient, but as a member of her own family. That day, you are all different, doctor. Nothing is tested in entrance, but this is the real entrance of life when you practice tomorrow. First carpal bone to ossify. Capitate. Please don't forget. Capitate within 1 to 3 months. It undergoes ossification. Hamate is 2 to 4 months. Pisiform is last 8 to 12 years is the time when pisiform undergoes the ossification is what you have to basically remember. Black foot disease is caused by what? Once more, doctor. Among the options available, which is more high yielding option? Always remember, that becomes the answer. Topic का नाम याद रहे तो you can still answer करके आ सकते. You know, of all poisonings, lot of time questions are asked on lead and arsenic more frequently. Okay, so arsenic. So this is how arsenic will lead to the skin lesions, which is basically called the black foot disease, which is caused by the arsenic, is what you need to remember. So arsenic can cause skin cancer, garlic odor on breath, excessive perspiration, muscle tenderness, skin pigmentation, paresthesias, peripheral vascular disease and gangrene, which is basically called the black foot disease, is what you need to remember. Very important question. What is the Geneva Declaration given for? It is for the ethics. Then Tokyo, they spoke about the torture. Oslo is for torture, and Oslo is for abortion, and Helsinki, about the human experimentation, they have developed the guidelines, is what the history of the medicine. Now, what are the various toxins, poisonings, substance abuses, and what are they associated with famously? So you should remember, Hunan hand syndrome is also called chilli burn. It is a cutaneous condition where large batches of roasted chili, if the people are processing, their hands develop the lesions, which is called as the Hunan hand syndrome, is what need to be remembered. Cocaine को बहुत names है. In Netflix and Amazon Prime, there are a lot of movies on all that hooligans, the drug lords and all that. Sometimes when your mood is little low, no? एक war movie, एक bank robbery movie, or a strategic movie, or a diplomacy movie, or a biopic, that inspires you back into the game, right? So, Coke, Charlie, White Lady, Nice Crack, Stones, Rock, Pebbles, Bass, Free Bassy, they're all the ones. Cocaine, yes. Ethan Hunt says, oh, you also have Netflix subscription. Yes, sir. Some of you students are joining in UMedico and paying subscription fee. With that money, I am able to buy Netflix subscription. So please do join and subscribe for the video library. You have that 9008685356, and you can always WhatsApp. And all these videos that we have discussion are all uploaded there for you to do the revision any number of times. Yes. Purple haze. It is a name for a clearly purple marijuana. So LSD is also called purple haze. Abrus precatorius. It's commonly called Zequirity, crab's eye, rosary pea, paternoster pea, love pea, precatory pea, prayer bread, coral bread, Indian licorice. And Gujarati में बोलते हैं कि Gumchi, Chanoti, they're all the names given for the Abrus precatorius is what you have to basically remember. Shika Munka is asking, where is the note, sir? Just give a little time. The notes, today morning onwards, I'm sitting with the developers. The notes, they are developing nicely where you can, each point, whichever point you want, you can bookmark it. And you will keep getting notifications and reminders about that particular bookmarked point. You can add images, some handwritten notes about that particular point for others to remember, you also to remember. So we are doing that application, now they are in testing phase. 1 week में ready हो जाता, तब आपको पूरा जो भी class हो रहा है उसका notes become available point wise on the UMedico app. So entry wound has been done. To know the distance, is it a close range gunfire or far away? How can you be able to know? Hair will give you a very important clue. The shining or the clubbing of the hair, burning of the skin, the powder tattooing, or a circle or a elliptical wound, that gives you a clue whether it is a contact wound or a closed margin wound is a very important question. No satellite pellet holes will be there in case of a contact or closed wound. Annular abrasion or an annular bruising will be there, and cherry pink tissue in the wound track, they are all the important clues. Autopsy of a woman brought dead to the casualty was done. On external examination, only a mark on the chin, as shown in the figure, a mark on the chin you are able to see, right? Now, what is the most likely cause of death? This was a question in AIMS November 2017, May 2017, also 2 times asked. That's the reason I'm saying. Types of asphyxial deaths: hanging, strangulation, right? Throttling, bugging. Favorite question. You can't get out of that. You have to mug and master that table, right? So on the UMedico app, within a short period of time, you can even bookmark. Okay, this point I am going to forget, so let me bookmark. What is the size of the sand particles in the rapid sand filter? Oh my God, I'm going to forget this. Let me bookmark. Let me set up a reminder. And suppose if you have set about 1000 points as reminders, in 24 hours, it keep sending you 1000 divided by 24 means how many? 25 per hour, for example. How many it will be? Around 40. 40 per hour, it keep showering you with the reminders, so that it keep telling you. And the moment you are sure that I remember this point, you can go back to that point and then unremind it. Once more, it goes back into the all points. So that is how we are creating a mobile tool for you in the UMedico app to help your preparation and create reminders, right? Then you also thought that, let me set a reminder about this point to my friend who is also on UMedico app. Even you can share that, so that your friend also will start getting notifications about what you set as a reminders. But for that, your friend should give you a permission to set reminders on his behalf. So it is like a typical educational Facebook for education kind of a application. So this is throttling. So throttling hota hai, examiner will do it in the exam hall. He will ask you, what is the size of the rapid sand filter particle? He holds your neck and say, will you tell or shall I kill? So you should not go into that situation. You should be counter-attacking, expecting what examiner is going to ask. Yes, that feature is coming shortly. MedQuest. Another 1 week, 10 days we will come up with all the notes available on the UMedico app. Don't worry. So if you look at the strangulation, there is a ligature strangulation or a manual strangulation which is called throttling. So in the postmortem findings in throttling, you will find a ligature mark and etc. etc. Now, you have been shown oral polio vaccine. You can see the various color changes. Based on the color changes, which should be considered, which should be discarded. Such a fundamental question, if you could not answer it correctly, means it's a social responsibility of MBBS pass out. Because polio vaccination, that means not a single day also we bother to open the polio vaccine container, how it looks like. That should not happen. Suppose you find this white mark, that means it is good, utilize it. If the color code is black or if the entire ring is not showing any label, that is bad, don't utilize, very bad, don't utilize. And if it is white but little lighter gray, then it is still good, you can still utilize. So it is the temperature sensitive color coding which is there called vaccine vial monitor is what you have to basically remember. Chronic liver disease is classified into class A, class B, class D, etc. This kind of a scale को क्या बोलते हैं? This question was asked at least 30-40 times in the last 15 years. So if you could not answer this means there are about 10,000 people ready to answer and move forward you. So you should be good with. So what are the different types of scales? Nominal, ordinal, interval, ratio are the 4 kinds. The names itself will make you to remember them easily. Nominal, ordinal जो होता है qualitative, they talk about the quality not quantity. Interval and ratio scales they talk about quantity. So what is nominal? Basically you will assign response to different categories. Gender 2 तरीके का होता है दुनिया में लोग, मेल फीमेल. मैरिटल 2 तरीके के होते हैं, मैरिड सिंगल. Similarly, the zip code, the student ID, the state of residence, the college major, these are all quantitative ways by which names are being given to every category, right? So if you take cats का family में black cat, green cat, pussy cat, lion, tiger, cheetah. So that is a nominal scale. That type is called nominal scale. Ordinal. These are the ones which are categories, but they are ordered from least to most. So if you take male and female in the gender, you can't say female first, then comes male. Bolke, can you order by superiority? You can't. If you do that, women's world will not let you to do that. But in ordinal scale, you can do that. Military rank, general, major general, lieutenant colonel, colonel, corporal. Oh, by mistake एक rank वाले को दूसरे rank बोले तो थप्पड़ मिलेगा, right? So ordinal scale is all you can order the things, but there is no numerical distance between the two. A general becomes major general maybe in 1 year, 2 years or 3 years. There is no numerical distance between the two. That is the most important point. Interval scale, the scale with values, and there is a same numerical distance between each value. For example, temperature. And how appealing is this cereal box to children? -3, -2, -1. The feedback on the Uber or Ola or Murali Bharadwaj's classes you can write on the Google review, right? So please, you guys should write every day. End of the day, go to the UMedico's Google Play Store. Even if you have written a review yesterday, you write another review today, right? The more number of reviews are there, UMedico app comes up in the order, and that is the best help you can do to your teacher, who then can buy the Netflix subscription and watch movies. If you buy the UMedico subscriptions, that is the exchange deal, right? So interval scale. Now ratio scale, what is that? The name itself says the scale which allows you to make ratio comparisons. Like, what is the weight of a package of a candy? My packet is 10 times heavier packet than you. As kids we used to fight with our sister, no? So that is example of ratio scale. You can't use ratio scale to show your wife. My wife is 10 times beautiful than your wife. That doesn't happen because beautiness is beholder's eye. It doesn't fall into the ratio scale, right? Now, a doctor uses a highly sensitive test and the result is positive. What does this mean to say is a very, very important question. It's a rare disease, highly sensitive test. So positive predictive accuracy is also high. So that is the reason it is highly likely that the patient is really having the disease is what you have to remember. For a rare disease, when the positive predictive accuracy is high, whenever the sensitivity is high. So if you look, true positives, false negatives, true negatives. These row entries determine the positive predictive value. How many true positives are there? How many false positives are there? We'll talk about positive predictive value. These false negative and true negative will decide the negative predictive value. Whereas for the sensitivity, what is important? All people who have the disease is important. So true positive and false negatives are important to calculate sensitivity. False positive, true negative is important for calculating the specificity is what you need to remember. So what is the formula of positive predictive value? True positive by all positive will give you positive predictive. True negative by all negative, including false negative, gives you negative predictive. Then what is sensitivity? True positive divided by all people with disease gives you sensitivity. And what is specificity? True negative by all the people without disease will give you sensitivity. So if you look at the numerator of the positive predictive value, you have true positives. If you look at the numerator of the sensitivity also, you have true positives in the numerator. Highly sensitive test means the number of true positives are also high. So that means the positive predictive value also becomes high. That means a highly sensitive test has got, in a rare disease, has got a great chance of typically producing a higher positive predictive accuracy is what you have to basically understand. By 31st March 2016, what is the annual new case detection rate of leprosy? Leprosy का पूरा SPM, PSM एकदम पढ़ना है. If you are not sure about this question, that is the whole purpose of the story. Leprosy माइक्रो में आता, डर्मेट में आता, मेडिसिन में आता, पैथोलॉजी में आता, SPM में आता. इतने जगह पे लेप्रेसी अगर आ रहे तो लेप्रेसी के बिना पेपर रहता क्या? अगर एक जगह पे मिस हुए तो दूसरे जगह पे आता. So that's the reason you have to be doubly sure, right now. So it is 9.7 per 1 lakh population is the annual new case detection rate. And these are the questions examiner will throttle you. You don't know, that's all. Clean bowl, duck out. It's like first time you are wielding your bat and wicket gone. Even you are the opening batsman, no one can help. Now, supplementary nutrition, midday meal program mein, what is the way you provide protein? Half of the total protein requirement, 1/3 of the total energy requirement is the one which you need to provide in the midday meal program. Midday meal program is sponsored by which ministry is another favorite question. I leave the literature for you and you must be doubly sure, right? Is it by the school education or is it the social welfare or the health department? Which sponsors the midday meal program is a favorite question of the examiner. A lot of times students do wrong. In a statistical study, to calculate the drug effect on the sugar levels, the test showed significant difference, whereas in the reality there is no difference. So what is this kind of an error called? One of the favorite questions of the examiner. There is something called null hypothesis. Null hypothesis बोलता है, you take coaching or you don't take coaching, फर्क कुछ भी नहीं पड़ता. और null hypothesis में से, if you take coaching definitely you are better than not taking coaching. Another null hypothesis bolta, unnecessarily you waste your time in coaching classes, there is a greater chance of failing. That is another kind of a null hypothesis. Finally, you are a poor guy, you don't know what to be done because this is the first time you are doing. So आप 10 फ्रेंड्स से मिला है जो टॉपर्स थे, वो बोला कि भाई कोचिंग ले लो, मैं भी कोचिंग लिया, मैं शेर बन गया, तुम भी शेर बनोगे. Another 10 said, अरे यार कोचिंग जाने के पहले लास्ट बिफोर ईयर लिखे तो मुझे 10,000 रैंक आया, कोचिंग लेने के बाद मैं क्वालिफाई भी नहीं हुआ. You don't know what to do. So null hypothesis assumes something and you do an experiment and you get the results. Now, what is the meaning of alpha error and beta error? Suppose if the null hypothesis says there is no difference, but the test is showing the results that there is difference, उसको बोलते हैं alpha error. So type 1 and type 2 errors बोलते हैं इसको. If you happen to reject the null hypothesis, here what are we rejecting? We are rejecting that there is no difference. There is no difference बोल के बोल रहे. So we are rejecting that. And on the contrary, test has shown that there is a difference. So if you reject the null hypothesis, though the null hypothesis is true, then that is basically called the type 1 error is what you have to basically remember. Suppose the null hypothesis is false, right? But if it is null hypothesis is false, if somebody gives you a false advice, ideally you should be able to reject that false advice. But if you fail to reject that false advice, then that is called as a beta error. एक right advice को आप reject करें तो बन जाता type 1 error. एक wrong advice को reject नहीं कर पाए तो वो बन जाएगा beta error. That is what you have to basically remember. How will you remember in the real situation? Alpha होता है अग्नि परीक्षा. A for alpha, A for अग्नि. सब लोग क्या बोले? भाई भगवान राम, सीता is very good. सीता साध्वी है. She is noble. Please don't doubt her. But राम ने क्या किया? The null hypothesis proposed by the world is true. He rejected that and asked Sita to enter into Agni Pariksha. So that is what? Agni is alpha error, type 1 error. Then how do you remember the beta error? The null hypothesis is false. दुर्योधन ने बोला, दुर्योधन कौन है? बेटा, बीटा, है ना? दुर्योधन ने बोला, पिताजी ये पांडव को कुछ भी नहीं देना चाहिए क्योंकि they don't deserve it. That is false. But धृतराष्ट्र ने अब क्या किया? He failed to reject the wrong advice of his son. That became the beta error, otherwise called beta error. Okay? So that's what you need to remember. So the alpha error is called a producer risk. That is a type 1 error and you are entertaining false positivity. Beta error is called consumer risk and you are entertaining and breeding false negativity. And the correct decision is called the power of that experiment, that is equal to 1 minus beta is what you have to basically remember. Right. A patient with a history of sudden onset palpitations, and there is a narrow complex tachycardia. There are no P waves, and the heart rate is 160, BP is 96/68. What is the next step in the management is a very important question. So, any tachycardia, there can be two ways by which origin. Can you please give me the whiteboard? There are two ways by which arrhythmia arises, doctor. SA node is pacemaker. Atria is also an arrhythmogenic tissue. And you have a AV node. AV node can also take over and can become arrhythmogenic. Then you have the ventricle. Ventricle can be a source of arrhythmia. Accordingly, you have SVTs, supraventricular arrhythmias, and VTs, which are ventricular origin arrhythmias below the level of the supraventricular structures. How to recognize whenever tachycardia is there with an arrhythmia in a patient? Look at the QRS morphology. If the QRS is narrow, then if the arrhythmia is happening, then what is the source of this arrhythmia? It is a supraventricular tachyarrhythmia. And if there are no P waves means, obviously it is originating from atria. Unless atria contract, depolarize thoroughly, then only you get the P wave. P wave nahi hai to the source is not SA node or AV node, but it is atria. That's what you will basically conclude. Whereas ventricular arrhythmias, they are the broad QRS complex arrhythmias. So all BCTs, unless proven otherwise, they are all basically the ventricular tachycardias is what you need to remember. Why is that so important for you as a clinician? Any tachycardia is tachycardia. Patient ko comes, you found 170, 180 pulse rate running. Look at the ECG monitor. It is narrow complex. Oh, narrow complex means supraventricular. So the most important supraventricular structure is SA node. So if the arrhythmias are originating supraventricular, if you can calm down the SA node, how can you do that? Carotid massage. If you do, vagus is close to the carotid, and that lead to slowing down of the SA node. But when you do carotid massage, don't forget, don't do both the carotid same time. Then you will be completing the God's work. The work started by the God, you will be finishing it and killing the patient. So one carotid at any given point of time. A good number of times an SVT will resolve if you do the carotid body massage, is what you need to remember. But if it is a VT, ventricular tachycardia, then you look whether he is hemodynamically stable, blood pressure kaisa hai, or he is hemodynamically unstable. If he is stable, you can try lignocaine, A shock, B shock, shock. You can give imidazole, beryllium, lignocaine, etc. But if the patient is in hypotension, that is an indication for electrical defibrillation. Shock is what you need to basically remember. So there is a little longer discussion on VTs and SVTs. Once more, UMedico video library and anatomy2medicine.com. We discussed both theory and also previous AIMS questions and DNB question bank asked on arrhythmias. Have a opportunity to bookmark it and review it. So doctor, any narrow complex tachycardia, irregular or regular? Irregular, no P waves, it is atrial fibrillation. If there are P waves, then it is a multifocal atrial tachycardia or atrial flutter with a variable block is what you need to basically remember. Then how do you manage? Acute episodes are managed by doing vagal maneuvers like Valsalva, breathing against forced glottis, carotid sinus massage. A simple thing, put the face of the patient into cold water, that itself stimulates the vagus. Then IV adenosine, or beta blockers, calcium channel blockers intravenously. If needed, DC cardioversion. Similarly, how do you prevent the SVTs? Beta blockers, calcium channel blockers, radio frequency ablation that will prevent the SVTs from developing is what you have to basically remember. What is the most sensitive index of the renal tubular function? Tubule ka most important function is to maintain the specific gravity of urine. If that is lost, if there is an isostenuria, that is an indicator that tubule got damaged, and you should think of all tubular pathologies, right? Like ATN, acute tubular necrosis, or a papillary necrosis. You should know the reasons for papillary necrosis, 4 or 5 reasons: sickle cell disease, analgesic nephropathy, diabetes mellitus, the causes of the papillary necrosis. You should be ready with the lists, bookmarked lists, reminders, ready to shoot the examiner. So, doctor, specific gravity and why it become elevated? Increase of proteinuria. And specific gravity also is a early manifestation of difficulty to concentrate the urine. So, decreased specific gravity is a feature when you take excessive water intake, chronic nephritis, diabetes insipidus. Increased specific gravity indicates diabetes, nephrosis, chronic renal failure. Fixed specific gravity, otherwise called isostenuria, is the earliest manifestation of the renal damage, is what you have to basically remember. A 53-year-old man with cerebrovascular accident, CT shows the midline shift with a very highly increased intracranial tension. How do you want to clinically manage? Very simple. That becomes, since there is a midline shift, that becomes an indication for decompressive surgery. Do a craniotomy and then decompress becomes a management. A patient comes to you and say, worst headache of my life. It's also called thunderclap headache. Classically means subarachnoid hemorrhage, where CT brain will help you. What do you see in CT brain? Typically, doctor, this is called Sylvian fissure. If the blood accumulates in the Sylvian fissure, it is a very important indication that it is a subarachnoid hemorrhage. Then interventricular area also blood is accumulated and the temporal horns became enlarged, because for the drainage of the CSF you require the arachnoid villi to be good. So any subarachnoid hemorrhage affects the drainage system, and enlargement of the temporal horns is another important feature, and the blood in the Sylvian fissure is what you have to basically remember. This is a beautiful question, doctor. Loud S1 kahan sunai deta? Labdab mein lab kab banta? Mitral stenosis. But though there is mitral stenosis, when will you don't listen loud S1? What makes mitral stenosis to no more produce a loud lab is a very important question. Of course, if the mitral stenosis is mild, or if there is an associated mitral regurgitation, so there are certain things that makes a loud S1 to become softer even though there is mitral stenosis. Let us talk about it. Typically, if you look at the first heart sound, it will be very silent and quiet, where if there is a low cardiac output or a poor LV function or a long PR interval or a mitral regurgitation. Why it becomes soft? The S1, why does it become soft in these conditions? First you should understand why the first heart sound occur. First heart sound क्यों होता है? It is the left atrioventricular valve, the mitral valve. So, can you give me the board? General medicine is something It is like a horizon for an eagle, like that for me. It is something that I can speak days together. Of course, SPM, ENT, Ophthal, anything we can speak. Only thing is if we prepare about the logic, reasoning behind the things, it is speakable. As simple as that. But let us talk why S1 occurred. So you have a left atrium and a left ventricle. Left ventricle opens the mouth into the aorta, and pulmonary vein brings the blood into the left atrium, and between the two you have the mitral valve. All of you know very well. Now doctor, why mitral valve closes? The left atrial blood fills into the left ventricle. How does it fill? The left ventricle filling of the blood from the left atrium has three phases. First 1/3, second 1/3, last 1/3. What is the meaning of that? When the left atrium got filled from the pulmonary vein, it is fully pregnant with the blood, doctor. That time mitral valve is in a closed state, and the left ventricle undergone isovolumic relaxation. Yahan ke pressures have fallen down inside the left ventricle, and this is fully pregnant with blood and with high pressure, and this has lost its pressure and it is at a low pressure. This pressure difference is there, no? That drives the blood to mitral valve open, and then it will jump into the left ventricle. First 1/3 is over. Shadi ho gaya, honeymoon bhi ho gaya. Then second 1/3. What will ventricle will tell? Come on, left atrium, you have vomited into me. I already have sufficient pressure. Jao jao. Why will I take the blood from you? Bol deta. But left atrium will tell, Newton, Newton, aajao Newton. It will tell, hey Newton, you are the one who found apple falling. Tell the left ventricle that story. Then Newton will tell left ventricle, देखो बेटा left ventricle, तू जमी के नजदीक में हो और left atrium तेरे ऊपर है आसमान में. So it is at a higher level than you. The gravitational pull will push some more blood into you. Accept it. Left ventricle says, okay, all right. Second 1/3 is over. Last 1/3 में the left atrium will wake up. Gravity का भी हो गया second 1/3. प्रेशर डिफरेंस के वजह से फर्स्ट 1/3 हो गया, लास्ट 1/3 आ गया, मैं क्या करूं? Then it will use all its muscles and contracts. So left atrial contraction contributes to push the blood in the last 1/3 is what you have to basically remember. So the left ventricle is now fully pregnant with the blood with a high pressure. And since it emptied all its blood at the end of the ventricular diastole, the left atrium is at a low pressure. Then the left ventricle will undergo isovolumic contraction. That means it will not eject the blood into the aorta, but it will undergo contraction. It will further increase its pressure. Its pressure will be so much high that it will then get the energy to close the mitral valve. Just like in aeroplane, the air hostess will come and push the upper luggage ones, no? The door, luggage door. Like that, it will push the mitral valve back. So the left ventricle should develop sufficient amount of pressure inside it for this closure to happen. Suppose you assume there is a ventricular septal defect. What will happen? All the pressure building in the left ventricle will push the blood from left ventricle into right ventricle, and it takes longer for the pressure to build inside the left ventricle. So that is the reason this pushing will not occur that forcefully. That is what you need to understand. So anything that delays the building of the pressure in the left ventricle will lead to a softer closure of the mitral valve is what you need to basically remember. For example, if there is a mitral regurgitation, let us say, what will happen if there is a mitral regurgitation? All the blood that is being filled in the left ventricle already is seeping back into the left atrium. That means left atrium did not lose its pressure fully, unlike a normal left atrium if there is a MR. So if there is a mitral regurgitation, that blood is seeping back, so the left ventricle pressure is not building that fast. So that is the reason the closure of the valve will not occur with that much of power. It will occur like a tired air hostess. She will slowly close the mitral valve. So if there is an associated MR or if there is a VSD, the left ventricular pressure buildup takes a longer period of time, and typically at that's called pressure crossover between atrium and ventricle. That will not lead to a thak bolke closure doesn't happen. So that is what you have to basically remember, responsible for the softer S1. Then why mitral stenosis leads to development of a loud S1 is a very important question. What happens in mitral stenosis? Typically in the mitral stenosis, the mitral valves, if you take, they both are stenosed. That means the ring became narrow, right? But because of this narrow ring, the blood passing from the atrium into ventricle is taking a little longer time. So that is the reason the both valves are wide apart. And when the ventricle build enough amount of pressure inside it after it got filled and undergoes isovolumic contraction, then it will close the valve, but that time the two valve leaflets are far apart, so the ring is narrow. So when the ring is narrow and the leaves are far apart and they happen to close, bhajan ka sound aata hai, bada sound. So that is the reason for the mitral stenosis, loud S1. But suppose if there is any calcification of these valves, or if they are degenerated valves, even if they are wide apart, when they close, they can't make much sound. So that is the reason that once more leads to a softer S1 is what you need to ultimately remember. So Shanti, Shanti, Shantihi. So the S1 is typically has got an atrial component, mitral component, and the pressure crossover where the left ventricle undergoes isovolumic contraction and LA happen to already vomited blood into LV is at a lower pressure point. When the pressure crossover happen, that is the point where the first heart sound typically seen is what you have to basically remember. So short PR interval or mitral stenosis or a hyperkinetic states like anemia, you find a loud S1. Then soft S1. If there is any ventricular septal defect or a aortic regurgitation or a mitral regurgitation, then in all these things the ventricular pressure does not build sufficiently enough that it can't close with a dub, with a loud lub. It cannot close because ventricular pressure is all being dissipated due to either VSD or due to AR or due to MR. In all these scenarios, you listen a soft first heart sound is what you have to basically remember. So that is the story, doctor. Valvular heart disease is one topic. Truly, you will get an academic orgasm. You have to, cardiology may 5-6 questions come out of 30. 6 out of 6 mark kya bahar nikalna hai if you are Dr. Murali Bharadwaj students, right? That's a deal. Hardly there are about 12 topics in cardiology. Very easy to master if you understand the logic clearly, right? With the proper physiological imagination about the chambers of the heart. During a routine follow-up of a hypertensive patient, you found that the right arm pressure is higher, left arm pressure is lower. What is the most likely causes for that? Coarctation of aorta, Takayasu arthritis, aortic dissection. In that, one arm will have a higher pressure compared to that of the other arm is what you need to remember. Not in supravalvular aortic stenosis is what you need to basically remember. Now, aortic dissection, subclavian steal syndrome. And why in Takayasu arthritis you have got one side pressure, one side pulse itself will not be there, forget about pressure. So, Takayasu is aortoarthritis, that is the arch of aorta got vasculitis. Because of that the subclavian got narrow and it is unable to push any blood into the upper limb on one side. Even if it pushes, it is at a low pressure and almost pulselessness will be there. So that is the reason Takayasu में unequal pulses, one arm में अच्छा है मगर दूसरे arm में कच्चा है. So that situation you can come across, right, doc? Now, normal anion gap metabolic acidosis. Once more, acid-base disturbances is another area. Without, you should never do mistake. You are able to answer correctly. You can say 10,000 students out of competition. Because that is one topic that, unless, that is the place where any classmate or a teacher should help you or any book should help you. You get a proper understanding. There are at least 30-40 topics where you understood it, you are ready with it, you attack it when it comes in exam, definitely going to come in exam. Suddenly your score goes to the top percentile. So this is one topic like that. So what are high anion gap, normal anion gap? Very routine question hai wo. So renal tubular acidosis, diarrheas, pancreatitis, these are all considered to be the normal anion gap metabolic acidosis. Once more, I like to advise you in the anatomy2medicine.com and UMedico video library, UMedico app video library, general medicine में, theory में, we have the normal anion gap metabolic acidosis, renal tubular acidosis, types of renal tubular acidosis, favorite topic of the examiner. They are already reviewed, videos are available in the DNB question bank discussion also. So please take a chance to review them and play quizzes. That's the way you should be ready for the exam. So cat mud piles, very old mnemonic. Cat होता है कार्बन मोनोऑक्साइड साइनाइड पॉइजनिंग कंजेनिटल हार्ट फेल्यूर में नॉर्मल एनियन गैप. कैट में ये होता है एमाइनोग्लाइकोसाइड्स. Then T is theophylline and toluene. Then M is methanol. U is uremia. D is diabetic ketoacidosis, alcoholic ketoacidosis, starvation ketoacidosis, any ketoacidosis. Then piles में P होता है paracetamol, fenformin, peraldehyde toxicity. I is the iron isoniazid and inborn errors of metabolism. L is lactic acidosis. E is ethanol, ethylene glycol, and S is salicylates. They're all responsible for a normal anion gap metabolic acidosis is what you have to basically remember. Salicylates, one of the favorite question. 3 types of acidosis can occur, doctor. When you take salicylates, toxicity, hyperventilation is what you see. When you hyperventilate, what will happen? You will be losing, you will be purging out carbon dioxide out of your body, right? So that is the reason it can lead to development of a respiratory alkalosis because of that. Salicylates are salicylic acid. Because of that, you will get metabolic acidosis. Then, after a period of time, the salicylates, because they are very strong cations, their abundance will lead to a normal anion gap metabolic acidosis. Finally, patient goes into respiratory depression. When he goes into respiratory depression and can't ventilate, he will go into respiratory acidosis. So all this, a respiratory alkalosis, respiratory acidosis, normal anion gap metabolic acidosis, and a high anion gap metabolic acidosis, all of them are possible with the salicylates, is what you have to basically remember. Now looking at this ECG, you can say one QRS is of a high voltage, other is a small. जिसका भी लंबी उसका भी बड़ा नाम है, जिसका QRS छोटी उसका भी बड़ा नाम है. So this alternating pattern is called pulses alternans, electrical alternans. So electrical alternans is a feature in cardiac tamponade when the heart is swinging inside the fluid in the pericardial cavity is what you need to remember. A patient comes to the emergency with a fever and headache. Proteins are high, mildly. Glucose is normal, very important clue. Lymphocytes are increased. What type of meningitis? Routine question. अगर ये क्वेश्चन भी रॉन्ग करे तो अगर आप आंसर रॉन्ग करे तो फ्री एडमिशन इनटू यू मेडिको ऐप वीडियो लाइब्रेरी. लेट मी चेक. Dhanalakshmi, call Bhagyalakshmi on our helpline. She will help you to get a free. Yeah, this is the place where tuberculosis funda gone wrong. Sorry for that. Yeah. So don't believe teachers' fundas always are right. Sometimes they can go wrong. It's not A. Please don't be angry on me. Yeah. So it is viral. The glucose is low, doctor, in TB. You should not do a mistake, right? So glucose is low in TB and also in bacteria. Hypoglycorrhea, viral and fungal fungal also low. Only viral glucose is normal in CSF. Protein is very high in bacterial, but protein is normal in viral. And RBCs can be found in bacterial. If you look at WBCs, they are more than 200 in bacterial, but viral it is less than 200. But if you look at the differential count, it is the neutrophil in bacteria, but lymphocyte rich in viral, fungal and also TB. And appearance of CSF is clear in viral, and cobweb appearance in the case of the TB is what you need to basically remember. Now doctor, a patient comes with ascites. Three things doctor: CSF, ascitic fluid, pleural fluid. Agar ye three fluids if you don't master, after the results come, you should be ready to become a Devdas and depend on some of the other hot fluid. So be very sure. SOG more than 1.1. So what are the causes for a high SOG, low SOG? You have to be doubly sure about. So high SOG means transudate. What is SOG? Serum ascites gradient. Protein is high in serum but low in ascites means it is a transudate. Low SOG means in the serum it is relatively lower and ascitic fluid mein jyada protein high means it is an exudate. So a low SOG is an exudate, a high SOG is transudate. First that you should be sure. Cirrhosis, CHF, tricuspid regurgitation, constitutive pericarditis, Budd-Chiari, portal vein, occlusion, myxedema. They are all the causes for the high SOG where it is a transudate is what you have to basically remember. By the way, tell me what is the difference between Budd-Chiari and portal vein occlusion? Lot of times students don't know what is portal vein, what is hepatic vein. Don't be angry on me. There are a lot of students who are not sure where is portal vein, where is hepatic vein. So you should be doubly sure. At least now tell me, portal vein is formed by the confluence of two veins. What are they? Coming from the intestine side. Should be an answer. Yeah? Oh, Ravi. Ravi must be joking by saying what is SOG. Serum ascites, albumin gradient. Right. Now, splenic and superior mesenteric. Beautiful. From the intestine, the two combine, form the portal vein and enter into the liver. Good. From where the hepatic vein comes out and where does it drain into? Hepatic vein comes out of the liver. All liver hepatic sinusoids will combine to form hepatic vein. Hepatic vein drains into inferior vena cava. Inferior vena cava goes to the right atrium. So that is what you have to be sure about. I know that you're all brilliant, but sometimes there will be confusions. So ये liver से बाहर निकल के IVC की तरफ जाते हुए हेपेटिक वेन के अंदर जब क्लॉट होता है उसको कहते हैं बर्ड-चियरी syndrome. Whereas portal vein thrombosis is when superior mesenteric and splenic happen to combine and form portal vein, the occlusion there is called the portal vein thrombosis is what you have to be doubly sure about. I am very happy to see 273 online across the country enjoying the AIMS question bank consumption, padafat, ready for the NEETPG 2019. Every day evening across 365 days with Dr. Murali Bharadwaj, and there are many other wonderful teachers in other subjects. But after January, when we start the next year, that time I will ask other teachers to take over the evenings when I can take a break. But always, I promise you, it will be free. Okay, good. So now, a young doctor comes to the blood bank. There's a platelet count of 1.9 liters. And he undergone platelet apheresis. And there's a paresthesia, circumvoral numbness and during the donation. So ECG shows tachycardia with STT changes. What is the reason for his main symptoms is a very important question. So very nice to see a lot of people to whom our students have shared. They're all joining the online classes. Good. Every day evening, please don't forget, we will all be meeting and reviewing for a couple of hours to get recharged. So doctor, hypocalcemia, absolutely right. ECG changes in hyperkalemia, hypercalcemia. Favorite topic of examiner. If one question inevitably will be there, doctor, you can't escape it. Hyperkalemia, very easy. 2-3 मर्तबे अगर इसको याद करें तो forever you will remember. No big science. What is there? There is one P wave, there is one QRS, there is one T, there is a PR interval, there is a ST. अगर वो नीचे जा सकता, ऊपर आ सकता, मोटा हो सकता, QRS can widen, QRS can narrow, QT interval can prolong, QT interval can shorten. Come on, doctor. You know your right hand is right side, left hand is left side, you know ECG, right? Hyperkalemia. Peak T waves. QRS के बाद जो होता है T wave. P wave become flattened. PR interval typically undergo prolongation. QRS become widened. That is hyperkalemia. Simple way to remember is all will prolong, only P will be disappointed in hyperkalemia. Only P become, देखो T तुम भी टालोगे, PR भी prolong हो गए, QRS भी widen हो गए, जाओ मैं flatten हो जाता हूं बोल के सो जाता, disappointment. That is hyperkalemia. Hypokalemia में T become flattened. T के बाद next wave is U. PQRSTU, that's what we learned. A lot of people think U is a negative wave. No, U letter is negative. But U also like T positive only. T के बाद आया इसलिए इसको U बोला. Not that it is negative. There are some conditions leading to a negative U wave. That is DM cardiology में पढ़ेंगे. अभी जरूरत नहीं है. ST segment becomes sagged down. It becomes low ST. That is what you see. A flattened T wave, prominent U wave and a low ST. That is ST depression is what you need to remember. Then hypokalemia also will, as the time progresses, causes further descending of the ST is what you need to understand. So once more, hypercalcemia में main difference क्या है? Hypocalcemia में QT undergoes prolongation, whereas hyper में there is a shortening of the ST segment and QT become narrower. That is what you see in hypercalcemia, is what you have to basically remember. Now a patient presents with a unilateral ptosis, hypotonia. He was given one injections and symptoms improved. That itself gives clue, no doctor, it is hydrophonium and it is myasthenia gravis. What is a big deal? Huh? No challenge in this question. Let me tell you, 240 questions, no challenge. You expect they come, you answer. 60 होता है, 60 में 60 are BMW questions. बकवास, mad, worst questions. वो BMW questions को तुम भी कुछ भी नहीं कर सकते. Always what do we pray God? God give me the strength to change the things that I cannot. I can. And give me an ability to accept the things that I cannot. And most important, the common sense to differentiate what I can and what I cannot. That's the only prayer to the God. Right? Even when you go to the entrance exam, 300 में 240 is what you can change your future. 60 bakwas, mad, worst questions. You can't do anything. But ये 240 में अगर कुछ गड़बड़ हो गए फिर और एक साल का जर्नी शुरू करना पड़ता. Right? That is what you should not. You should be well prepared. Attack, look for 240 and kill them. That's called shoot at sight. So doctor, in myasthenia gravis you have what is called Cogon's lid twitch sign, which is classical of myasthenia, where there will be a brief overshoot twitch of the lid retraction after sudden return of the eyes to a primary position after a period of downward gaze. Matlab, you ask the patient to look down for a while and then ask them to lift up their eyelids. Then what will happen? There is a brief overshoot twitch will happen, like frog eyelid. That is basically called Cogon's lid twitch sign of myasthenia gravis, is what you need to basically remember. What is the emergency management of acute hyperkalemia? Forget about entrance. As a basic MBBS student, where do you get in a casualty or an emergency situation a patient with hyperkalemia? Chronic renal failure patients. Commonly, why are they paraded to hospital? Uremia, hyperkalemia. If you don't jump and do intervention, they will arrest in the casualty itself. So how do you manage hyperkalemia? First thing, when hyperkalemia is there, heart ko bachao. Kaise bachate? Hyperkalemia leads to hypocalcemia, and that should be prevented by administering calcium. The purpose of giving calcium is not to bring down the potassium levels. It is to prevent the hypocalcemia from leading to cardiac arrest. Hypocalcemia that accompanies the hyperkalemia often. So that's the reason you have to give quickly calcium to save that. Then you will do various things to move the potassium into the cells. Potassium का स्थान कहाँ होता है? What is the natural place for potassium? Potassium is the principal intracellular ion. Sodium is the principal extracellular ion, is what you need to remember. So you can give insulin or insulin plus 25% dextrose. Insulin pushes glucose, pushes potassium into the cell, and serum potassium levels will fall down. Whenever you say hyperkalemia, where hyperkalemia? It is the serum levels in the extracellular place. Beta 2 agonists, terbutaline, subcutaneously. Beta 2 agonists typically move the potassium from extracellular into the intracellular. Don't forget one important fact. अगर आप ICCU में घूम रहे हैं या acute medical care unit, MICU में घूम रहे. What is the common reason for hypokalemia among our MICU, AMC, acute medical care or intensive care patients? Any intensive care में nebulization चलते रहता. All that nebulizers are pushing what? Salbutamol, salmeterol, for all the beta 2 agonists. It is that beta 2 agonists which will push all the available potassium into the cells and serum potassium levels will fall down. One of the common reasons, don't forget, in an intensive care unit when a patient has got hypokalemia is that nebulization with the beta 2 agonists which is being carried out leads to development of hypokalemia. Second reason, in an intensive care unit, why hypokalemia will be there? The nurse will come and tell you, doctor, yesterday the potassium was 2.5, today also 2.5, yesterday also I have given pot chlor syrup, given potassium administration as what you said, still potassium is not coming down. Common reason क्या होता है intensive care unit में when potassium hypokalemia is refractory to treatment, there will be associated hypomagnesemia. Ask the nurse to quickly send his serum magnesium levels. Generally hypomagnesemia will be there. Unless you correct the hypomagnesemia, hypokalemia does not resolve is a very important fact. So, beta 2 agonists move the potassium from extracellular into intracellular location and bring down the serum potassium levels. So that is the reason you can give beta 2 agonists. Then third important fact, a H plus ion hota na, which is responsible for your acidosis. H plus ion, K plus ion, they are like two sisters. They both want to marry the same guy. Who is that same guy? Cytoplasm inside the cell. H plus says, hey, I want to go inside. Potassium says, no, I want to go inside. But always in the war, H plus wins. Potassium loses. Potassium remain unmarried and outside the cell and serum potassium levels are high. So that is the reason, give bicarbonate, get this sister, H plus ion, get married, no more competition for K plus, then K plus will move into the cell and the serum K plus levels will come down. So that is the reason we give bicarbonate. If there is acidosis is what you have to basically remember. So calcium to manage hypocalcemia and prevent heart from going into arrest. Then insulin with 25% dextrose, beta 2 agonist and a bicarbonate. And you can also give diuretics that promote caliuresis like furosemide. Already we discussed now, loop diuretics lose potassium into urine, thiazide diuretics retain the potassium in the body. That's what we what you call calcium. If you take calcium, not only calcium, potassium. Potassium, both thiazide and loop diuretics will lose potassium, but loop diuretics additionally lose calcium into the urine, but thiazides will retain calcium in the body. Both thiazides and loop diuretics lose potassium into the urine. Both of them lead to hypokalemia. But we prefer to give loop diuretic like a furosemide. Then we can give resins like sodium polystyrene sulfonate to prevent the GI absorption of the potassium is what you have to basically remember. Then dialysis for the patients with renal failure. Hemodialysis is very rapid. One of the indications for dialysis is severe uremia with symptoms, severe hyperkalemia, or a pulmonary edema with a volume overload in a renal failure patient. That patient will be gasping and coming to you with pulmonary edema with chronic renal failure. That becomes indication for hemodialysis. Then ethylene glycol, theophylline like toxins removed with the dialysis, and the AV fistula in the arm is created surgically, and there are all the indications is what you need to remember. So doctor, what is the best guide to know whether your resuscitation is good or not? We used to have a professor. Doing rounds with that professor used to be very funny. Every bed he used to put down his head and look. As medical students, we used to surprise. Are क्या है इतना fanatic, obsessive about the Foley catheter? But later on, when we grew up, we understood, oh, how important is that? Urine output is the most important gold standard Supreme Court certificate. How good is your resuscitation is what you need to remember. What is that modified shock index formula is a very important question. So it is the heart rate by mean arterial pressure is a very good way by which you can grade the severity of the shock is what I like to underscore. 22 gauge, 16 gauge. Lot of times some areas nurses are much better than us doctor, be very sure. In internship, जरा उसको मस्का मार के 10 days is enough. All that knowledge will come to you. Practical knowledge रहता ना, how is IV nitroprusside is being administered, what will be the catecholamine drip in a shock patient and putting central lines. They know the trick. So you need to be very good with them. Sister Mary, I am silly, you are not silly, Sister Lily. You should take them for a party, for a good tea and treat them with a great respect. 10 दिन में वो पूरा वार्ड वर्क कैसे करना आपको सिखा देते. Even especially OT sisters, please don't forget. We used to still have Sister Geeta. As the interns, when we used to fold our back a little more and try to assist a hysterectomy, she used to hit the back and say, Aisa, if you happen to put your, if you are not maintaining proper positioning across the OT operating table, you will quickly catch a back so that you will not be useful for any of your girlfriends, doctor. She used to tell when we were all house surgeons. I still remember where recently I attended her retirement. So I reminded her what she used to tell to the young house surgeons about what is the proper posturing while assisting a surgery. So there are a lot of things that practically nurses teach you. So doctor, 22 gauge is 0.8 mm, 20 gauge is 1 mm, 18 gauge is 1.2 mm, 16 gauge is 17 mm. So you must be doubly sure that color coding is very important. 16 and 14 gauge, orange and grey. 18 gauge is green, 20 gauge is pink, 22 gauge is blue, and you have the 24 gauge which is yellow, and that is the one which is used in pediatrics and elderly patients. And slow speed infusions के लिए 22 gauge blue, 20 gauge pink is suitable for non-emergent blood transfusions. 18 gauge green is basically for a large vein, and 16-14 also for large vein and high risk procedures is what you have to ultimately remember. So for the transport of a traumatized and conscious patient, what do you want to basically do? So talk to the patient while he's on board, rolling without moving the spine, and on a hard board with the head and spine stabilized is the way you need to transport. In a school bus accident, you have a victims. What is your choice? Always A, B, C, D. A is airway, B is breathing, C is circulation. So A is a child with airway obstruction is the one which you have to basically remember. Last question of the AIMS question bank for the evening before we go to the quiz. Once more, examiner's favorite question is all color coding. Waste disposal color coding, cylinders ka knobs ka color coding, pin index, then everywhere color. You should be doubly sure on these colors. So in disaster management, what is the color coding of the triage is a very important question. So you should be sure a red tag means immediate, cannot survive without immediate treatment. Yellow tag, observation, need hospital care and do Retriage. Green tag, wait, he need medical care for critical injuries. White tag, dismiss, only minor injury, no need for medical care. Black tag, expectant injuries, not able to survive with the given care. So that is a different color coding which you have to basically remember. So we will take up by tomorrow evening 1 hour में हम AIMS November 2017 खत्म करेंगे. Let us take up the quiz, doctor. Unfreeze your fingers, get ready for a challenge, and let us see how good you are in the today's quiz. Today quiz? Yes. Start. So welcome all. A mother in the village. Is it the same today quiz? आज का quiz है. Please recheck. Can online students can punch? Today quiz? Yeah, good. A mother in the village has brought her 1-month baby with a complaint of fever to the PHC. The baby is irritable but able to feed. The baby does not have chest indrawing. So 671. What is your answer, doctor? Give one strong answer. Yes. Ethan Hunt proposes pneumonia. Okay. Then no pneumonia by Sudhakar. Gangadeep is confident of very severe pneumonia. It is a severe pneumonia. So there is a classification based upon if he stopped feeding, convulsions, abnormally sleepy, wheezing, fever or low body temperature, very severe pneumonia, refer urgently. Severe chest indrawing or fast breathing makes it severe pneumonia. And no pneumonia when there is no chest drawing and no fast breathing. So that is how you triage the patients into different categories. Next, doctor. 70-year-old diabetic, hypertensive, investigated for angina and coronary angiogram was done. His BP increased to 180 by 100. Creatinine pre-angio level of 1.2 became 3.6. He has eosinophilia. Then what is most likely true statements about it? So if you come by 5 p.m., you will get a chance to answer, have a group discussion before we go to the quiz. That makes the answers faster. Yes. Nishant Gupta proposes C. Lavanya also says C. But it is the kidney biopsy that will show a microvessel occlusion with a cleft in the vessel. So this is basically called atherosclerotic renovascular disease, and they do very badly with the dialysis, and clock instability will be there in them. So that is the story of this entity, clock instability in atherosclerotic renal vascular disease. Now, Schwarzman's reaction is what type of reaction is my question to all of you. Shoot your confident answer, doctor. 673. Yeah. Time for you to punch the answers and I tell you you are right and wrong. Very good. Ravi bets on type 3. Sorry, type 2. Ritu proposes type 1. And Deepayan says type 2. Good. None of this is true about Schwarzman. Schwarzman is not a hypersensitivity reaction at all, is what need to be remembered. It is basically a rare reaction of the body to a particular toxin called endotoxin that lead to thrombosis of the tissue. And the clearing of the thrombosis will lead to the reticular endothelial blockade, and that prevents re-clearing of the thrombosis by the repeated toxin activity, and that lead to tissue necrosis in Schwarzman's reaction. Nothing to do with the hypersensitivity is what you have to basically remember. Pomphylix. What is except about it in case of the pomphylix is a very important question. 674. Please punch your answer, doc. Right. So Amrit says, sir, this revision is too much for the FMGE, right? No, no, FMGE is younger sister of NEETPG. पहला इसको शादी करके आप नेक्स्ट एल्डर सिस्टर को टारगेट करना है. सो दोनों का एक ही स्टोरी बोलना पड़ता. सो द सेम स्टोरी अप्लाइज फॉर दैट आल्सो. यस. नाउ pomphylix, I can see Fahad Khan proposing A, Sindhu saying C, and Gurjar, he promised 500 students waiting for it. Absolutely right, Gurjar, that topical steroids are useful. 50% have atopy. Pruritic tapioca vesicles on the palms. These are called tapioca vesicles on the palms. In case of the pomphylix, you can see classically how the pomphylix lesions. Tomorrow, who knows, November 18, 2018, November AIMS question, a image of the pomphylix can come. Pomphylix is eczema affecting the hands and the feet. It is also called dyshydrotic eczema, and it is related to sweating affecting the young adults is what you have to basically remember. Now, doc, most used endometrial ablation technique currently, 675. What is your answer? Give one strong answer. $675. Vinyl proposes rollerball. Kushbu and everyone strong on laser ablation. And Rocket says transcervical resection. Did anybody say balloon? Very good. Mukaddir Jamal is proposing thermal balloon ablation. Right. Yesterday, a group of students from Pakistan joined the classes. I'm very happy. Pakistan also has similar entrance like NEETPG, right? Very competitive. So, whatever our top politicians are, I'm very sure that anywhere we go, doctors as a community, we're all the same breed and race. So, I'm so happy that now we became transnational with Nepal students and Pakistanis also attending this session. Very good. Ultimately, human care is same, knowledge is same, medicine is same, right? So, let's take up this important question. It is the roller ball thermal balloon ablation where you put up a balloon, heater rises fluid temperature, and that typically lead to the endometrial ablation is what you need to basically remember. Yeah, Muktadir, I know that you are from India, but I'm saying that there are a lot of students from Malaysia and Indonesia, other countries also, right? Now, this is how typically the fluid filled balloon goes in and the heater rises the fluid temperature and endometrial lining is being ablated. Now, doc, buprenorphine, what type of a property does it have is a very important question. Good. The other day in AIMS question bank, we have seen about naloxone or one of the opioid drugs, right? 676, right? So I can see good number of you answering it as partial agonist of mu receptor. Very good. Partial agonist of mu receptor. So you have heroin, which is the full agonist, buprenorphine partial agonist, naloxone, which is the antagonist, is what you have to basically. Pentagocin that day, correct. Ashima rightly reminded me. Pentagocin the other day, we had that question. This picture depicts photos of 4 patients being asked to open mouth as much as possible, which is true about them in terms of Mallampatti classification, or do they depict varying degrees of hypoglossal nerve paralysis or tonsillitis? What is your answer? 677, I can see a lot of you saying option B. Okay, option B. That's good. Mallampatti classification. Before you give anesthesia, you should know whether I can intubate this patient easily or not. How is his pathway? So you will know adequacy of his oropharyngeal area for you to pass the endotracheal tube. If you can see the hard palate, soft palate, uvula, pillars of the tonsils, that is class 1, easy to perform. But if you get a Mike Tyson like guy, class 4, short neck, and you can't see anything, how will you put endotracheal tube? Very difficult. So that is class 4, difficult. Mallampatti type of a classification is what you need to remember. About the rotator cuff tendinitis, what is except about it? Sorry, yeah, rotator cuff tendinitis. What is your answer, doctor? Yeah, give one strong answer. Yes. I can see most of you answering it as C. That's right. Steroid injections are given. Acromial beak of the bone appears with age, and injection of local anesthetic will help in diagnosis, and a painful arc causes secondary weakness. So this is how typically radiologically you can see the tendinitis of the rotator cuff. And the bony surface, bony spur on the inferior surface of the acromion is the one which is the underlying culprit. Now doctor, with regard to this picture, what is except about it? What you are seeing, what is this lesion? Most likely true statement about it. All are true statements except what? Should your answer, doctor? Yeah. Narsi Bajia is sure about A, that it is not umbilical hernia because it is not near umbilicus. Or about. Common sense is half excellence in NEETPG. Absolutely. But, sir, he has an umbilical hernia also, right? So, baby has a large right inguinal hernia. Surgery is indicated for the groin swelling. It is not the right psoas. Agar psoas abscess hai to, psoas flexes your hip. Patient will go into a hip flexion. He can't extend the hip at all. If there is any psoas abscess retroperitoneally, is what you need to basically remember. Yeah, umbilicus mein umbilical hernia bhi hai. 40-year-old multiparous woman, menorrhagia of 6 months duration, and Call Exner bodies are seen. Very important clue. What is your answer, doctor? 680? Yes, 680. Shoot one strong answer. Good. I can see most of you saying granulosa and rocket. You can't be bold on this. Yes. Call Exner. Somebody said call girl is a mnemonic. Yeah. Call Exner is granulosa cell tumor. Lot of times classmates only tell wonderful mnemonics, doctor. Very funny way. You know, you will laugh until getting umbilical hernia. Right? So, Call Exner bodies. Call girl. Easy to remember. Yeah. Whipple's triad is diagnostic of 681. Yes. Ravi is asking what is called Exner. Exner ko bulao. Hindi mein. Now, 681 May, everyone is proposing insulinoma. Insulin. Yes, I am waiting. Somebody will do wrong. But most of you are right. Whipple's triad, development of hypoglycemic symptoms like heart rate increase, etc. And same time detecting low plasma glucose. And if you give glucose, there is a relief of symptoms. It's basically called Whipple's triad. Now, with regarding the diagrams that are being shown, two types of diagrams, which is a bar chart, bar diagram, which is histogram, which is for continuous data, is a very, very interesting question. Once more, यही question November 18th exam में आए तो don't tell anybody who leaked the paper. That's good. Ethan Hunt, everyone is saying C. Good. And Sheikh Kuteja proposes D. Yes. Oh. Anuj Nigam 10 times on C. Commandant is firing on D. Anuj Nigam obviously is right. That you can draw a frequency polygram by connecting the top of all these bars. On the picture on the left is what need to be remembered, this one. So the left picture is a histogram. A histogram talks about distribution of the data of a continuous variable. And the right picture is a bar diagram, and a bar chart is typically plotted vertically or horizontally, is also called column bar chart. Now, bar charts are for the, bar diagrams are for the categorical data, not the continuous data, is what you have to basically remember. Ottawa ankle rules are basically used for what purpose? Ottawa's ankle rules is a very important question. Yes. Yes, 683. Yes. Rocket proposes C, and Praveen Dwivedi stands on C. So we have a horn lock between C and D, except Anuj Nigam says B. D is right, that to decide the need of a X-ray for a possible fracture, Ottawa ankle rules or the guidelines is what need to be remembered. Ankle X-ray is only required if there is any pain in the malleolar zone, and along with that any other things like any bony tenderness along the distal 6 cm of the posterior edge of the tibia, etc., etc. Lot of times patients will have a little fall and worry, oh my God, my ankle has a fracture bolke aate. So how many unnecessary X-rays you need to take? So Ottawa decided, let me tell high prediction of need of the X-ray or not. Now, in the smear, what you are seeing, what is the most likely diagnosis is what examiner is asking you. Yes. Shoot me the question, answer. I can see C, Lalit saying AML, good. Krityantava saying ALL. So there is a horn lock between A versus C. It's a clear cut of OR rods and AML. Even this question you should not do wrong. So this is how the OR rod, which is azurophilic condensation, abnormal condensation is what need to be remembered. Under revised nasal tuberculosis program, what is the category and the color of the drug box of the sputum smear who are treated after default? What is the category? What is the color? Shoot your answer. I can see Raju doctor saying B, Ravi says C, Praveen says B. Okay. So all the juggle is between B and C predominantly. So B is right. You should remember category 1, color of the box is red. New sputum positive, seriously ill sputum negative, seriously ill extrapulmonary. Category 2, color of the box blue. Sputum positive relapse, positive failures, sputum positive treatment after default. Then you have category 3, color of the box green, sputum negative, extrapulmonary but not seriously ill, like lymph node TB is what you have to remember. Accordingly, the various regimes and their indications, you should not forget. I leave the literature. Right. Now, a 6-month-old infant presented with recurrent polyuria, dehydration, and hypercalciuria, medullary nephrocalcinosis, then what is the most likely condition that the patient will be showing? Sodium is 130, potassium is 3, and bicarbonate is 30, pH is 7.48, and creatinine is 0.4, and hypercalciuria is there in this patient, 686. I can see Ashima confident on Barter, Itian Hunt also, Arpita also, but Chaco, Fahad are betting on distal renal tubular acidosis. Barter, the other day we discussed, no doctor. So Barter is typically urinary calcium excretion is high. Gitelman is like thiazide diuretic. So thiazides retain calcium, loop diuretics lose calcium. So Barter also, like Lidl, will have calciuria, which is a very important clue. So the last question for the evening before we sign out. Identify Machar Pakdo. Identify the mosquito. Don't dishearten if you don't know how to मच्छर पकड़ना अगर नहीं आए तो अभी सीख लो. सब लोग एनाफिलस मच्छर को पकड़ सकते, काट सकते, बोल सकते, देख सकते, except Ravi thinks Aedes. Okay. And Shoaib Bhagat thinks Mansonites. Tuskin Jambuswarala also thinks Mansonites. Anopheles, doctor, Anopheles. You should remember different types of mosquitoes, which will have siphon tube, which will stand stylishly like a red light area, and which will be ready like an aeroplane to take off. All these things, how it is standing so beautifully, proposing, you must be very sure. So, Anopheles and Aedes and Culex on the right. That's how you compare between the two. So with this, doctor, let us call it a wonderful day ahead, long evening, and we will meet tomorrow once more. And please punch your, call 9000868356, the number you are seeing above, and WhatsApp, take a subscription in UMedico for the video library, mocks, mock tests, and call another 10 of your friends to join tomorrow. Every day evening will be across 365 days available. Don't forget, after you sign out, go to the UMedico in the Google Play Store and write a little comment, a good comment with a 5-star rating. And every day once you do that, our rating will go up. Thank you very much.